So it's my honor to introduce Lisa Schoyer, the founder and past president of RASopathies Net, and current secretary. And I think potentially most importantly for this presentation, Quinn's mom.
Thank you. So I had the thank you. I had the opportunity this time to be able to be in the conference, so it was pretty exciting as a parent of a child who died of cancer related to the RASopathies, which was rhabdomyosarcoma. So I started as an artist, and this is actually a piece of work that I did of an installation, and that's Quinn's hand. And on the vitrine, there's a silkscreened image of the ultrasound that was within normal limits, the karyotype that was within normal limits, and then a description by Dr. Rena Falk of all the dysmorphic features. And then the hand is the fist that was cast because that was the resting position. So yeah, I wanted to be a professor of studio art, and I wanted a perfect pregnancy. I was gonna not have amniocentesis, and I wanted to do the water method of birthing, no pain. That didn't work. So I did get an amniocentesis because of my age, and it was like within normal limits. And of course, then things went left when we needed to do a C-section because they were worried based on head circumference that I'd have shoulder dystocia during birth. But he was large for gestational age. I had polyhydramnios, which is classic for the RASopathies, many RASopathies pregnancies. C-section at 38 after having oligohydramnios, which was unique to the RASopathies. Pretty typical, all that stuff blow by, rule out sepsis, minor congenital anomaly, hypoglycemia, macrocephaly. And so he stayed for 8 days and then was released from the NICU and looked pretty, they looked at their toes, they looked at his toes, looks the same to me. They looked at his depressed nasal bridge, it's like, I got that too. So we weren't quite sure what was, if there was any real concern. And then he went into failure to thrive. So I was reminded of when I read Dr. Zampino's description of Costello Syndrome, the marasmic phase. Marasmic. So fortunately, we got a G-tube, and that plumped him up there at 7 months. But before that, at 5 months, he developed severe HCM and the right hip subluxation. So things to look forward to. At 17 months, he just barely had enough trunk support to hold himself, so it was very safe. That's the Buddha picture, I call it. And then this is after his resection of his left ventricular hypertrophy. And then a bunch of stuff happened and things settled down. And with the help of 2 parents who had children, one with Costello syndrome and another with cystic fibrosis, they said, you should have another child. And it's like, ooh, I don't know. And after some counseling, my husband also agreed. So 5 years later, here comes Turner. You saw her around, she had to go early. So missed her. So this time it was Turner crying instead of Quinn. And then cancer happened, and I want to share Helena's story because it folds into ours. Helena got cancer, I think, several years before Quinn. And then the second relapse was just before Quinn's. I think that's right. Yeah, 96 and 98. So you can see Helena's trajectory is very similar, Costello syndrome. And there she is after chemo started with her IV. And so while we were dealing with the cancer, when he was out of the hospital, this is the kind of stuff that we were managing in a, hopefully I'll, it's like snow you over by throwing all this stuff at you. So, the providers, the medications, the PRN medications, a lot of GI stuff. So here now the chemo parallels. Here's Helena at 2.5. What? Yes, they both look alike. And so, and this is both of them after their tumors had to be resected, which was not the plan. The plan was chemo, then it's small, and you decide if you need to take it out or not. And often they just leave the dead tumor in the body. But both Quinn and Helena got their first VAC. I think you didn't get anything after. Anyway, vincristine, actinomycin, and cytotoxin. I think those are the three. And so both of them here looking very similar in the ICU. So the similarities, we had the same starting chemo. The reaction was the same after, soon after, both of them had to stay in the hospital for 8 weeks. Quinn lost his ability to walk. He had to learn again. Did Helena? Yes, both of us. So same. So it was suggested, but there's no way to test that it might have been a cytokine storm. Who knows? So it's like I want to warn any parent or any doctor just to keep that in mind as a what do you call it? In advance of possible left turns. The tumor appearance for Quinn, it did not seem to have penetrated his bladder, and Helena's, the first one did not either, but the second one was in the uterus, right? So, and then the relapse diagnoses challenges, Helena was able to get doxorubicin, which was swapped out after a month with topotecan, and Quinn got doxorubicin with irinotecan, which did not help. Neither of our families chose radiotherapy. At the time, Quinn, we thought he was cleared. We had gone through all the whole course, and it looked like it was gone, but on retrospect, about 5 months later, there was this ribbon behind basically along the back spine that looked suspicious, but then it clearly grew into a mass. So at the time, we didn't want to do radiotherapy because it would have messed up his hip and killed or stopped the growth plates. So he would have been, at 6 years old, it would have been really weird. Oh, same with Helena. Okay, so not a good place for radiotherapy. A big difference is that Helena had Professor Eden, and Professor Eden was the head of the NHS oncology, like for all of England, sitting next to Helena. And so he had researched that another child with Costello syndrome had died of Katie. Yes, and she was 4. Yes. So she died with the usual chemo dosages, and I knew that, and I tried to get our doctors to call Professor Eden. And, UCLA, they're the best in the world. We know what to do. We'll call. And so apparently they, tried once. Oh, he didn't answer. So we just continued. And I think it is definitely more, I know it's aggressive, but it's even more aggressive in Costello syndrome. So we had a lot of complications, which is also like typical of Costello syndrome. It was like, you think you're going along and everybody thinks things are going, by the book, and they always find some way to get you on your toes. So the slow emptying, which we had talked about on Friday morning, it's so slow after NPO post anesthesia that the typical 10 cc's an hour and then increased 10 cc's an hour is too much. And every time, the young doctors, I went through like 2 cycles of interns, residents, and they'd say, "Oh, look, the book says 10 cc's an hour." I said, "It's not going to work." And they kept saying, "Look." And I said, "You do it your way. He's going to throw up, and then we'll have to bring it down." And so it was 5 cc's an hour, but we had to put him through that. So that was very frustrating. We had difficulty with nurses not following hygienic protocol, which was pretty scary to watch them change the Hickman lumens without washing their hands. So I caught that. We had a GJ tube to help with the nausea, since we had a G tube anyway, but he kept coughing a lot. So we had to reposition it 20 times in a year. So that was no fun. And then we had a really weird experience because Quinn didn't know how to spit. He would swallow the Paradex, and he was getting dexamethasone for one of the side effects of the chemo, which narrowed his airway, which with the mucus overproduction made it very difficult to de-intubate him. So we decided on a trach, and that was yet another terrible story of getting that put in. So I wanted to share this last picture here, Quinn with this friend that he made. The only time he had an opportunity to make friends, you know, in the hospital child life says, "Oh yes, we'll take care of your kid, you know, he'll be socially fine." And it was like, stay here, okay, you can do coloring, but we don't want HIPAA broken, and we don't want the kids to infect each other or whatever. But this boy, Frankie, he came from Bakersfield and didn't know what they had. He was there for a day, and then they realized he had leukemia, so they took him away. And they took him away when Quinn and I were out doing our regular walking. We were going to come back and, you know, we're going to do our walk. We're going to see you when we come back. And when we came back, he had gone. The bed was made. It was like he'd never been there. And Quinn's whole body went. So I think, you know, I want to advocate for thinking of the whole. Oh, I'm going to go this should be backwards. But anyway, I want to advocate for considering the whole child in every situation, especially when they're in the hospital where it's very lonely, and give them a chance to make friends, because otherwise, you know, with a neutropenia, it's hard to be exposed. So this came up in a training that I did, and was part of for my salaried job. And you know, when I saw it, it was like a really good metaphor. And I also think about it with everybody in this room, the motivation you have is growing around the grief of somebody you know. So I thank you all for being here and just committing to the RASopathies, or RASopathy families. It was really great to hear Keir and the GI doctors talk about the whole person. And this is the WHO International Classification of Functioning, Disability, and Health. And hopefully it's familiar to some of you, any of you, where, you know, the health condition is one thing. It does affect the whole person, but there are all these other categories, and you can actually do a training. It's like 12 hours, all web-based, so you can pace yourself. But really thinking about the body functions, how it affects everything, you know, and the whole point really is the activities piece. What can that person do? And so thinking about how we all plug in to help a person be a whole person in their community. So that's my wrap up. Thank you. And I want to introduce you to Helena. Helena, who survived 2 bouts of cancer and a whole bunch more, and is a dancer at the Blackpool competitions in England. All right, thank you. Next person. Oops, there.
All right, maybe we'll save questions for the end if that's okay. I'm not sure this is the right next talk. Sorry about this.